Right. So we'll start with the sir, with the permission from all the faculty, sir, shall we start with the program, sir? Dr. Rashid, sir, shall we start with the program?
Yeah, of course. Sorry. Go ahead, please. Can you hear me? Hello?
Yeah. Yes, sir. Yes, sir. We can definitely hear you, sir, now. A very good evening to all the doctors who have joined today, and we are doing a program in the month of World Thrombosis Month. So just few days back, we have celebrated the World Thrombosis Day, and it was a pleasure with interacting with the various doctors and discussing about the VTE awareness and what they have been doing in the VTE management. And today, in few days' time, we were able to get this program with the help of faculty from India as well as from overseas. My name is Dr. Anup, and the medical lead for thrombosis division and for the division of cardiology at Emcure Pharma in India. I'm also joined with the division head at Emcure, and also my colleague Dr. Ronak from the medical team, who is handling the cardiology and thrombosis along with me at Emcure Pharmaceuticals. I would like to also say good evening to Dr. Ashit Hegde, sir, who has given us this opportunity today. Very good morning to Professor Gregor for accepting this invite, and also to Dr. Prabhu, sir, for giving his valuable time. So without much ado, let me just share my screen and give a brief intro about our faculty for today's program. So to begin with, Dr. Ashit Hegde, sir, who doesn't require any introduction, who is a senior consultant in medicine and critical care section. He is the section head, general medicine at PD Hinduja Hospital. He has been a mentor to many Indian students. He has been a mentor and he's guided students in India. He has been a pioneer in the field of medicine, and we had the pleasure of having him in the past few years. And it's a great pleasure to always hear Dr. Ashit sir in various conferences, and we are really thankful to you for providing us this opportunity, sir. I welcome you on board today, sir.
Thank you, Dr. Anup. Thank you.
And we are also happy to welcome Professor Gregor from Ottawa, Canada, and he's a professor in the division of, he's a senior scientist, clinical epidemiology, and he's been in part of a
Apologies, I think there is some network lag which Dr. Anup is facing. I would like to share my screen instead. Just give me a minute. Is my screen visible?
Yes.
Perfect. Perfect.
Yes, it's visible.
You can move ahead with Dr. Gregor's introduction. Don't go back
Yes.
to that.
So, of course, Dr. Gregor doesn't need any introduction, but sir is a professor and a division of hematology at the University of Ottawa and a senior scientist, clinical epidemiology program, Ottawa Hospital Research Institute in Canada. So, sir is a pioneer in his field, and we are really thankful for him for accepting this invite today. So, welcome, Dr. Gregor.
Thank you. Thank you for
We
having me.
also have Dr. Prabhu Pandurangan. Sir is a consultant hematologist, hemato-oncologist at the Apollo Hospitals, Chennai. So thank you so much, sir, for accepting the invite, for being a speaker here today.
Thank you.
Great. With this, I would just like to show the agenda for tonight. So we'll have Dr. Ashit sir, who's going to be the moderator and going to give a small context setting on VT in hospitalized special population. Professor Gregor will go ahead and talk about the thromboprophylaxis in special populations, especially renal failure and obesity. And we have Dr. Prabhu, who's going to have a case-based discussion on the treatment and/or prevention of the recurrence of VTA. So with this, we can begin the program. So Ashit sir,
Well, thank you, Ronak. And I think we all know that nowadays the low molecular weight heparins and direct oral anticoagulants have more or less replaced unfractionated heparin and warfarin for almost all indications, barring, of course, a few special situations. Obviously, these drugs have several advantages, and one of the advantages is that their pharmacokinetics are very predictable. Therefore, dosing in most patients is fairly standard and not very complicated, which is why most clinicians tend to prefer to use these drugs nowadays. Unfortunately, a few gray areas remain about dosing of these drugs, and especially in situations like obesity, which is of course a strong risk factor for the development of DVT, but dosing of patients with these drugs in obesity, is we are always concerned because at the moment in our country, monitoring factor 10A levels are not easily available. So monitoring of these drugs in these special situations is not always easy in our country. Similarly, in patients with renal failure who also are at risk of both, bleeding and DVT. Again, dosing in patients with renal failure, the guidelines are not very clear. So in these situations, most of the clinicians are resort to empiric therapy, and we're not always sure that we're on the right track. So I think to lead us from darkness to light, we have two experts here, and I won't come in the way. So I request Professor Gregoire to begin throwing some light on how to deal with the special situations where dosing recommendations are still not very clear. Over to you, Professor Gregoire.
Thank you very much, and thank you again to Dr. Anoop and to EmcureCV to have me today. It's always a pleasure to share with you all. So let me share my screen. I hope you can see that. Yes,
Yes,
I
sir,
see you
please.
can. Very good. So over the next few minutes, we'll try to review the global burden of VT, review the importance of thromboprophylaxis, and then see maybe how to target our prevention strategies in some specific subgroup of patients. I always like to remind people of that because I think when we all, Dr. Anoop, you mentioned World Thrombosis Day, and it's we want to raise awareness, we want to reduce the burden of the disease on the society. And if we want to do that, the issue with thrombosis is that often there is not much that we can do because most of the events we see are unprovoked, right? They happen out of the blue. So it's hard to target prevention. But if there is one area where we can do a better job, is certainly patients who are admitted to hospital, and I will show you why and how. So overall, as you know, I used to work in Brittany, France, like the tip of the nose of France, and which was kind of nice for epidemiology because then we could capture all the cases that were diagnosed in that area, and we knew that we had an exact view of what was going on, and that helped us defining the incidence of the disease overall, which is between 1.5 and 2 per thousand per year. But what we did is that we repeated these exercises over time based on census years in France. And in one of these exercises, we looked at where was the patients coming from, or whether we could find a cause for their VTE. And what was interesting was that although most patients were outpatient at the time of their VTE diagnosis, a significant proportion of them were inpatient, some were in long-term care. But among the outpatient diagnosed with VTE, when we did ask them whether they had a recent admission to hospital, that was true for almost 1/3 of them. And so if you combine the ones who were diagnosed during a hospital stay with the ones who had a recent hospital stay, then overall, it means that more than 1/3 of all the VTE we see are somehow provoked by a stay in hospital. And so again, if we really want to reduce the burden of VTE on the societies, really, I think hospitalized patients would be the target of our efforts in terms of doing a better job at reducing the risk. And as you can see, out of these, we had a good proportion coming from medical wards, actually more than surgical wards, where sometimes we're more aware of surgically provoked VTE, but in fact, most of the patient would come from medical wards. So that made that hospital-acquired VTE gain the name of the silent killer, right? And also because, well, silent killer, because what we got to realize, and these are all studies for most of them, but to say that actually PE is responsible for 15% of all hospital deaths, and that in most cases, actually the vast majority of cases, nobody suspected that they had a PE before they died. So either the diagnosis was missed, symptoms were missed, or death was the first manifestation of the disease. And so when you look at the epidemiological data in Europe, again, most of the fatal VTE that we see might actually be due to a hospital admission. So just brief overview on medical patients, and I know we started a bit late due to technical difficulties, so I will try not to spend too much time on that. But just to say, as it was said already, that low molecular weight heparin clearly became our first option for preventing VTE in hospitalized patients. This is based on these very large randomized clinical trials like 20 years ago, showing a very significant reduction in the risk of VTE when using a low molecular weight heparin versus a placebo. And as you can see, there was no significant increase in the risk of major bleeding when using low molecular weight heparin in medical patients. Some meta-analyses were performed later on, showing that not only it did reduce the total rate of VTE, which on my previous slides were it also including asymptomatic VTE, but it does certainly reduce by more than half the risk of symptomatic PE, the risk of fatal PE, and the risk of symptomatic DVT. So why wouldn't we use a DOAC in that indication? It would be very appealing, right? Because of the cost of the injections and the inconvenience for the patient. But so far, except for some countries like rivaroxaban in the US, for example, most countries did not approve the use of DOACs for prevention in medical patients based on the result of these two clinical trials, one testing the apixaban as prevention dose, the other one testing rivaroxaban. And as these were non-inferiority trials, trying to show that the DOAC wouldn't do worse than low molecular weight heparin. And what happened was that the rivaroxaban trial managed to do that. Like the overall rate of VTE was not different than on low molecular weight heparin, but there was significantly more major bleeding events on rivaroxaban versus enoxaparin 40 milligram. In the apixaban study, you also had an increase in the risk of major bleedings that did not reach statistical significance, but it looks like the magnitude of the effect is roughly the same. And despite the fact slightly more VT events, but they failed to achieve their non-inferiority margin. So they failed to demonstrate that, for sure they weren't worse than the enoxaparin by a certain amount of clots. When you look at the data, maybe there would be room to redo something like that, but I don't think it has been tried thus far. But again, that's the reason why low molecular weight heparin would really remain our main tool in medical patients. So what's to be done then? Well, the issue for that is that based on the first trials I showed you, initially people were very enthusiastic, say, oh, such a great reduction in the risk of VT, let's give it to pretty much everyone. But then we got to realize that some patients bleed, and also that when you look at symptomatic events or fatal events, not every patient will benefit because their risk is not always high. And that led to the concept of risk stratification. And so now the guidelines say, well, if someone is at high risk of clotting, low risk of bleeding, then you should give it. But if they have either a low risk of clotting or a high risk of bleeding, then you should not. And the issue is that it's not easy to identify such patients. So many clinical decision rules, Padua score, improve, or the NICE checklist, have been proposed. But the reality is that still it remains a challenge to determine, again, who is most likely to benefit. So I think the challenge we have now is implementation, and we have the guidelines, we might have the tools, but so far implementation rate is very variable. This is a very old study, so I'm sure the numbers have changed since then, but you can see that across countries on a given day, proportion of patients felt to be at risk of VTE was rather homogeneous across countries around the world, but the implementation rate, that is the proportion of patients at high risk who were actually receiving low molecular weight heparin, was highly variable from one country to another. So that's really where we have to work on, make sure that we do what we would be supposed to do. Moving to surgical patients, where maybe things are felt to be a bit easier. And the reason for that is that often the surgical procedure in itself is sufficient to trigger a decision or a guideline recommendation for thromboprophylaxis. So typically, patients undergoing hip or knee arthroplasty, regardless of other factors, pretty much, that they will have to be on thromboprophylaxis. Still, there are, many and also significant trends in the surgical world where fast-track surgeries, reduction in hospital stay, much faster recoveries, and so on, which makes that the risk has changed, and the risk-benefit assessment is sometimes getting a bit trickier to do. And certainly also important to take into consideration that sometimes, even if it's kind of a simple surgery, patient-related factors or underlying condition can affect also the risk. And I always like to remind people that a minor surgical procedure in the eyes of the surgeon, it's not complex, it will be short, but still could carry a major thrombosis risk if the challenge to the hemostatic system has been significant during the intervention, even if it was short and easy. So on the surgical world, beyond the guidelines that are specific to some surgical intervention, the most widely used clinical decision rule is the Caprini model. You can see here that based on some either patient risk factors like age or varicose veins or some thrombophilia, but it also takes into consideration the type of surgery or other comorbidities that the patient might have that might influence the risk as well. It was felt a bit to be overestimating the risk. So in their last edition, the American College of Chest Physicians adopted a revised version where they also highlighted a bit more clearly where some surgical procedures would stand in terms of the risk. But the nice thing is that it gets you an estimate of what would be the baseline risk of VTE if you were not to give thromboprophylaxis to these patients. And then you can go on to decide which regimen do you think they need. High risk recommendation would be to use low molecular weight heparin or unfractionated heparin, sometimes along with mechanical prophylaxis. While, as you can see, if they're very low risk or low risk, you would say no need for pharmacological thromboprophylaxis. Let's go with early ambulation or mechanical thromboprophylaxis as well. In terms of the risk of bleeding, because that's always a particular consideration in surgical patients for sure, we don't have a good clinical decision rule per se. What we do have are risk factors that have been identified that are listed here. I don't think you will be surprised by any of them, but certainly when you have a patient that meets these criteria, a special caution is advised, or sometimes holding a bit on the prophylaxis for the first few hours, or making sure the dose is appropriate, trying to mitigate these risk factors like hydration and other parameters that we sometimes have a bit of control on. I wanted to just say a quick word about cancer patient as well, because that's maybe a domain where things have changed a bit as of late. As you know, a bit like what we just said for surgery, right? Cancer and thrombosis risk is influenced by many, many aspects, some of them being related to the cancer itself. So we know that metastatic cancer would carry a higher risk, and we know also that the pathology type or the location of the cancer will influence the risk. And then other factors would be more patient-related. Some will be treatment-related as well. We know that some chemotherapy, hormonal therapy, the use of central venous catheter will further increase that risk. And we do have some biomarkers. Some of these tumors, particularly activating the coagulation or releasing microparticles, tissue factors, active, and that could also increase the risk of cancer-associated thrombosis. So what do we do about that? Something that's well established now as well is that, for example, in cancer patients, I skipped my slide on cancer patients being admitted to hospital, and clearly all the guidelines say that this being a major risk factor, they should receive thromboprophylaxis when they're admitted, regardless of the reason why they're admitted. This is a slide to show that among surgical patients, the ones who have cancer do have a higher risk of VTE, do have a much higher risk of major bleeding as well. And many studies have been done trying to compare short-ish duration of thromboprophylaxis, which was kind of inpatient or up to 2 weeks. And in that systematic review, comparing short duration to extended duration for up to 6 weeks, there was a very significant reduction in the risk of VTE when using extended thromboprophylaxis without a significant increase in the risk of major bleeding, which, and likely the reason for that, when you see that, you might worry about bleeding here, but the thing is, it's often front-loaded after the surgery, right? So if yes, cancer patient will bleed more, but they still, like, the risk of VT will persist over time, whereas the risk of bleeding will likely go down a few days after the surgery. And maybe likely that's why they benefit so much from thromboprophylaxis during an extended period of time, because their risk persists for several weeks. And actually, when you look at the guidelines, across the board, everybody would say that patients undergoing cancer surgery in many cases would require extended thromboprophylaxis, and it's mostly 4 weeks. That's the recommended duration. What's maybe a bit newer is ambulatory cancer patients undergoing chemotherapy. I'm sure you've heard of the Corona score that was developed in the database of cancer patients on chemotherapy. And it managed to show that this, without surgical intervention, that's just a natural incidence of the disease in these patients. And as you can see, quite significant numbers of patients. And based on this very simple predictant factor, you can risk stratify your patients. And the patient who has the highest risk, actually, up to 1 in 10 or 1 in 5, will develop a symptomatic VTE during the 6 months after being started on chemotherapy. So quite an impressive high number if you consider things. And that led to clinical trials being performed to try to address that. This was the AVERT study carried out from here in Ottawa by my colleague, Dr. Carrier. And so what he did is that he took patients who had starting chemo and who had a Corona score of 2 or greater and randomized them between taking 2.5 milligram of apixaban twice daily or a corresponding placebo, and to take that for up to 6 months. And the primary outcome of the study was a composite endpoint of symptomatic DVT, symptomatic or incidentally found a PE on a staging CT, for example, and VT-related death. There was also a key secondary efficacy endpoint of all-cause mortality, and the primary safety endpoint was the risk of major bleeding. And when you look at the primary efficacy outcome, it did show a significant reduction in the risk of VTE in patients maintained on apixaban 2.5 milligram twice daily for 6 months versus the ones who were taking a placebo pill. And that led the most recent edition of the ASH guidelines to recommend that ambulatory cancer patients at high risk of thrombosis, they suggested thromboprophylaxis with a DOAC. I didn't show you, but there was an equivalent clinical trial, the Cassini trial using rivaroxaban over no thromboprophylaxis. And if you do that, as you can see, a very important reduction in the risk of VTE, and you will spare 46 fewer Ps per 1,000 patients, 37 DVTs, at the expense of causing 9 more bleeds per 1,000 patients that you treat. And some cost effectiveness analysis showing as well that it's actually a cost saving intervention to do. So moving on now to some specific settings or how to adjust as my colleague was saying in the introduction, we still have some gray zones or some subgroup of patients in whom like evidence is a bit more limited, and then we move a bit more to the art of how to do things, right? One of these subgroup clearly is patients living with obesity. We do have some limited data from the bariatric surgery world, right? And we don't have large clinical trials that would compare different dosing. What we have are several pilot trials, observational studies, and overall there is a consensus to use higher doses of low molecular weight heparin than the typical 40 milligram, and also to extend for at least 2 weeks after the surgery. But that's another domain where things have surgical intervention has been much simpler, recovery time has been much shorter, so it is also a moving field. But as you can see, when you compare VTE like the VTE risk using weight-adjusted doses versus the fixed regular doses, it sounds that the risk of VTE is significantly lower when you do increase the dose based on the patient weight, and that actually you do not increase the risk of major bleeding when you do that. Again, grain of salt, because it's or word of caution, because it's not data from clinical trials, it's data compiling observational data. We also have some biological data, and that's obviously indirect evidence, right? Because as you know, well, you were saying that you don't have always access to anti-10A levels in India, but and so certainly some studies have used it, but as you know, we don't have, it's not like an INR or a PTT where we have a very clear nomogram of what to do, right? For anti-10A, what we have are, previous studies showing pretty much on average how much anti-10A is circulating in a patient who received whatever dose of that blood thinners, but the correlation with clinical events is less easy to establish. So that being said, so that's, for example, a pilot trial, 91 patients who had an average BMI close to 40, and they started them either on a regular dose of enoxaparin, 40 milligram daily, and the other part was getting a higher dose of 60 milligram daily. And as you can see, you had many more patients reaching the usual range, so to speak, when you were using 60 versus 30, difference was versus 40, sorry, and difference was even more striking in the group of patients weighing more than 100 kilo, and you significantly reduce the proportion of patients who had an anti-10A below the usual range that was observed. So again, not to say that it's definitely better, but it looks like at least by doing that, you correct a bit that propensity of obese patients to have lower levels of anti-10A. So I would say it still remains an evidence-free zone, and we have a lot of debates about the volume of distribution, whether subcutaneous absorption remains the same in patients with major obesity. That being said, or our local practice, or some overall what you would see in many papers are, okay, used 40 to 60 up for BMIs up to 40 kilo per square meters. Generally speaking, above 40 kilo per square meter, people start using more like 40 twice daily, and sometimes up to 60 milligrams twice daily in patients whose BMI is greater than 50, particularly if they are felt to be high risk or to undergo, or if they undergo bariatric surgery. And we can come back to that in the discussion as well. Kidney failure. So that's another interesting one, and another tricky one in practice as well, because I think on the obese patients, we're clearly more worried about the risk of clotting. In patients with kidney failure, it's the opposite, right? We mostly worry about risk of bleeding if we do too much, kind of thing. So just to illustrate that, a quick clinical case, no need to spend much time on it, but just to say a typical 82-year-old male, a patient being admitted to hospital for decompensated congestive heart failure. He's allowed to go to the bathroom, but he's on oxygen, so he's mostly stuck in bed all day long with a past history of hypertension, type 2 diabetes, a previous infarct. So he's on metformin, ACE inhibitor, some aspirin, and a beta blocker. His blood work on admission, he's a bit anemic. His creatinine is 128 micromole per liter, and with his body weight of 74 kilograms, that corresponds to a creatinine clearance of 41 milliliter per minute. So questions for you would be, what's his thrombotic risk? What's his risk of bleeding if I give him some thromboprophylaxis? What should I give then, and at which dose? Let you reflect on this for a second, and for the sake of time, just to say, on the thrombosis risk, say I use Padua score, which is the one that the ACTP guidelines are using. I will say, okay, he has a reduced mobility, he's an elderly patient, he has heart failure, so he scores 5 points, which classifies him as being high risk with a threshold that's usually for scores of 4 or greater. So he has a high risk of thrombosis. If I look at his risk of bleeding, we don't have super good predictive tools. The only one we have is actually the IMPROVE score out of that IMPROVE cohort that I showed you earlier. And if you look at that, he's a male, he's age like 82, so he scores 1.5 point here. His risk of bleeding is therefore 2.5, looks relatively low, like 1% or something like that. So if you go to the guidelines, he's here, increased risk of thrombosis. He is not bleeding or not high risk of bleeding. So recommendation will be, yes, you need to give him some thromboprophylaxis. Should you worry about his age or his kidney function? Clearance was 41. Well, and should you say, oh, because of that, I would rather use unfractionated heparin? In that guy, I don't think so. And as you know, when the clearance is greater than 30, we have kind of a good amount of data, clinical trials comparing enoxaparin versus unfractionated heparin, BID or TID. And as you can see, the enoxaparin is clearly much better than the unfractionated heparin at preventing blood clots and without causing an excess risk of bleeding. So clearly in that patient, I would not go for unfractionated, and I would use low molecular weight heparin. Do we want to reduce the dose because we say, oh, he's old, he's a bit frail, he's on aspirin? Well, the issue with that is when you look at the Medenox trial, which I showed you before, the ones that demonstrated the superiority of Enox 40 versus placebo, they also had actually an arm of patients receiving enoxaparin 20 milligram daily. But as you can see, very disappointing results, right? And pretty much whether it's for all VT, proximal DVT, or for PEs, the 20 milligram of enoxaparin was acting pretty much as a placebo. And only the 40 milligram daily here in green was able to show superiority as compared with the placebo. So a big, warning of not to reduce the dose in patients who are eligible for the regular dose. And in the Medenox study, patients were excluded if their creatinine was, they didn't do a clearance. They said exclusion if creatinine is greater than 150 micromole per liter. And I show you here, because sometimes we're partially concerned about elderly patients, and this is a subgroup analysis of the Medenox trial by age group. And as you can see, what I just told you about the lack of efficacy of enoxaparin 20 stands true even in the oldest patients. And if you look at patients aged 70 to 79, risk of VTE 18% on placebo, 15 on 20, whereas it was much, much lower on 40. And the same in patient greater than 80 years of age. So, again, if the clearance allows it, I would just stick to the regular dose. But then obviously it's not always as easy, right? And if I take the same patients, but now his creatinine is 208, which corresponds to a creatinine clearance below 30, so around 25 per minute, are my answers still the same? Or so do I say still keep going with the 40, or do I say, better to use mechanical method only? Or in this instance, should I reduce the dose or switch to unfractionated heparin? Well, clearly the difference here is that below 30 of clearance, you start to see evidence of accumulations. This is again anti-10A based clinical trials, where they looked at 125 patients, very, very old, frail patients, like average age was 87 years. They had a relatively low body weight as well. And of these, 40 of the 125 had a clearance below 30 milliliter per minute. And as you can see, it like the curve, the average anti-10A is pretty much flat based on creatinine clearance as soon as you hit 30 or greater. But when you are below 30 milliliter per minute, you start seeing evidence of higher average anti-10A level, indicating probable, bioaccumulation in these patients if you use enoxaparin. So that's why below 30, it starts to be a bit of a different discussion. Would you switch to unfractionated heparin? Well, sometimes that would be sticking to the devil we know, right? And I like that study where they compared the risk of major bleeding in patients with normal kidney function versus patients with altered kidney function. And they showed that whether you use LOMO or unfractionated heparin, clearly the risk of major bleeding is much higher in patients with altered renal function. But look at here, right? It looks like if you use unfractionated heparin, even in that subgroup, well, the risk is even worse than if you were to use low molecular weight heparin. So again, sometimes we feel we're doing the right thing by switching, but in fact, it looks like the risk of bleeding is still quite significant, which is what was shown earlier as well. So what do we do then? And admittedly, relatively limited numbers. And then when you stratify, so half of these were on unfractionated heparin. So, I'm not saying that's set in stone, but, again, word of caution there. So maybe that's where the dose reduction is warranted. And despite of what I said earlier about Benelux, which was in patients with normal kidney function, here, when the clearance is below 30, the product monographs do recommend a dose reduction to 20 milligram daily, and the product monograph in Europe or India to 30 milligram in the US, for example. Just to show you some data from Ottawa here as well, where my colleague, Dr. Castellucci, did a pilot trial a few years back, where she took 30 ICU patients who had severe renal failure, so below 30 milliliter per minute. We used enoxaparin 30 milligram daily and did anti-10As on them after 2, 3, 4, 7, and 10 days. And as you can see, if you use the dose reduction, despite the kidney function and the median creatinine clearance was 23, all the anti-10A values were within acceptable range, and there was no evidence of accumulation when you do that. So it looks like by reducing the dose when the clearance is below 30, you might limit the risk of bleeding, yet you are hopefully protecting your patient sufficiently well. Although again, we don't have large clinical trials to demonstrate that. Let's keep on with our what if, and now let's say his creatinine is 400, and his clearance is then now below 15. Well, then again, I don't have much to offer you here in terms of advice, except, well, at least, certainly don't do that. That we know, like usually these patients, again, they do have a risk of clotting, right? That's not the question. So if you feel that you cannot use any thromboprophylaxis at all, certainly mechanical methods, why not? But that's where one of the situations where, I think the risk of accumulation would be significant enough, even with a reduced dose, that your only option then is to switch to unfractionated heparin if the risk of bleeding isn't too high. So whenever the clearance is below 15, then I think we should avoid using low molecular weight heparin. We don't have any data except for some data for the prevention of clotting formation in hemodialysis circuits. But other than that, that's where we would use unfractionated heparin instead. So looking forward to the questions and the discussion, but in summary, just to say that again, that we continue to have a problem with hospital-acquired VTE, and if we want to reduce the global burden of the disease, we need to target that population. And it's a unique opportunity to reduce the burden of the disease. What's very fundamental these days is to assess the risk of the patient on admission, but also every couple of days, right? And including, I didn't go into that, but including on discharge, where you have to wonder whether, some patient might require extended thromboprophylaxis after they go home. And that's a question that we need to ask ourselves as well. Low molecular weight heparin remains a cornerstone of thromboprophylaxis in medical patients who are admitted medical patients. I showed you that the apixaban in ambulatory cancer patients, also rivaroxaban is an option, and sometimes as well they have been used more in patients who get extended thromboprophylaxis post hospital discharge as well. But obviously the challenge through the end of the presentation where we were going through the subgroup is that we don't have strong evidence to support the best practices. And I will let you with these words from Professor Hunt in the UK in an editorial in the BMJ, strongly advocating for the right of patients to have a safe hospital stay, and that includes preventing VTE, which will save lives, reduce morbidity and mortality, and reduce the incremental cost of VTE to the healthcare system. And with that, I thank you for your attention and look forward for the discussion.
Thank you, Professor Gregoire. We'll take questions at the end of both talks. So I now invite Dr. Pandurangan Prabhu to present a few interesting cases, and then, of course, which will probably set the stage for the discussion later. Over to you, Dr. Prabhu.
Yes, I'm just sharing my screen. Sir, you're on mute, Dr. Prabhu.
So
just a second, I'm sharing my screen.
Just while you're sharing, I just thought what I intend to do in the next 15 to 20 minutes is to kind of go through the data on incidence of venous thromboembolism within Indian hospitals and in the Indian community setting, and to kind of make the audience aware of the risk of venous thromboembolism within our management strategy on a prevention. It's a case-based discussion. I think thromboembolism, the previous presenter, 100,000 people hospitalization, with PE accounting, pulmonary embolism accounting for 10% of inpatient mortality. So it's a very significant number. So in hospitalized medical patients, patient-specific and disease-specific risk factors and the interactions increase the magnitude and duration of the venous thromboembolism risk, which again was very well illustrated by Professor in his talk, where you have to look at your patients admitted and categorize them into high or low risk of thrombosis. And of course, you need to balance the risk of bleeding and give appropriate thromboprophylaxis. And in certain patients, you may have to extend the thromboprophylaxis beyond the duration of hospitalization. Next slide, please. So what are the main risk factors for venous thromboembolism in patients who are hospitalized? Age above 60 years, infections, a high inflammatory milieu like with a CRP of more than 10 milligram, a high D-dimer at baseline, patients with tachycardia and patients who've got high white cell count and thrombocytosis, patients with leg edema, high fibrinogen, which again can contribute to high thrombotic risk, patients with recent knee surgeries who got central line, who have congestive heart failure or on hormone therapy,
patients with malignancy, and patients who are immobile. Again, pregnancy, postpartum. These are the patients who have a high risk of venous thromboembolism. And genetic thrombophilia, although its overall contribution may not be high, there are certain high-risk thrombophilia conditions which significantly impact upon the occurrence of venous thromboembolism when such a patient is admitted to hospital. Bed rest for more than 3 days, history of heart failure, autoimmune disease. These are all various risk factors that can contribute to thromboembolism in patients who are admitted to the hospital. So it's very important when you have an inpatient to carefully risk assess them for thrombosis and also risk assess them for bleeding and use the most appropriate thromboprophylactic agent. Next slide, please. So again, this slide tells you that there are several risk factors, which again we elucidated in the previous slide. So 75% cases have multiple risk factors, leading on to an 8-fold increase in venous thrombosis risk among hospitalized medically ill patients. So again, this particular slide emphasizes that each of us as clinicians have to assess our patients for thrombosis risk and actively consider thromboprophylaxis. Of course, one may decide against thromboprophylaxis depending upon the intent, depending upon the risk factor and the bleeding risk. But every clinician has to actively look for these risk factors. Next slide, please. So what is the consequence? What are the consequences of venous thromboembolisms? So estimates suggest that about 60,000 to 100,000 Americans die of venous thromboembolism. As many as 900,000 people could be affected by venous thromboembolism every year in the US. And sudden death can be the first symptom in about 25% of patients who have PE, pulmonary embolism. So it is extremely important to recognize venous thrombosis, to recognize risk factors of venous thrombosis in patients that we see and address the risk factor by appropriate thromboprophylaxis, because many of them may die due to PE and they may not have any preceding symptoms, which will make them come to the emergency. And 33% of DVT patients can have long-term complications. And also patients, once they have a DVT or a variable in very different subset of patients, but any patient with the venous thromboembolism has a high chance of recurrence, especially in the first 6 to 12 weeks of occurrence of the index event. Next slide, please. So disease burden of venous thromboembolism. About 10 million cases of VTE occur across the world. 70% of all VTE-related deaths are from hospital-acquired VTE, and up to 60% of VTE cases occur during or after hospitalization. So now we talked about a lot of global data. We sorry about my voice. We talked about data from the US. We need to ask ourselves, is this problem prevalent in India as well? And the answer will be a resounding yes, as you'll see in the subsequent slides. Next slide, please. So going back to my undergraduate years, which will be several, three decades ago, there was a perception, of course, a perception that is erroneous, that incidence of venous thromboembolism in Indian population was not as high as in the Western population. But a lot of observational studies have clearly demonstrated that there is no significant difference between incidence of venous thromboembolism in the Indian population in comparison to population from West. Next slide, please. So there are some studies, not big studies, but these clearly tell you that the venous incidence of venous thromboembolism in Indian setting is significant. There was a study from 2006 in Sir Gangaram Hospital. They looked at patients with DVT, and about 40% of patients with DVT had a high probability lung scan, and overall 47% of patients with a high probability scan had no clinical manifestations suggestive of PE. So a lot of patients admitted with DVT had a lung scan suggestive of PE, though they did not have any clinical findings suggestive of PE. So incidence of venous thromboembolism, incidence of PE within our cohort of patients with DVT is significantly high. There's an autopsy study from PGI Chandigarh done in 2007, which recorded pulmonary embolism in about 15.9% of autopsies done. And there's a study in 2009 from CMC Vellore, which looked at incidence of VTE, and it estimated a VTE incidence of about 17.46 per 10,000 admissions. So if you actively look for venous thromboembolisms in our patients who get admitted for either surgical or medical cause, you will find them in a significant number of patients. So it is no longer right to have that kind of conception that incidence of venous thromboembolism is less in our population compared to the West. Next slide, please. So there was a study in AIMS in 2009. 75% of patients had high risk of DVT and PE, and only about 12.5% had DVT prophylaxis within the first 2 days of admission. So this tells us that the awareness, this is of course from 2009, one only hopes that the awareness has increased and the percentage of patients receiving DVT prophylaxis will be much higher. But my experience within the hospital I work, again, is probably not at the optimal level it should be. And in this same cohort of patients, signs and symptoms of DVT and PE were present in 25.8% and 9.8% of patients admitted, and 16.2% of patients who had DVT or PE died within 2 weeks. So there's an ENDORSE study, the Indian subset was analyzed separately, and it was only noted that it's only 16.3% of surgical and 19.1% of medical at-risk patients received ACCP recommended thromboprophylaxis. What these two studies tell us is that though there is a recognition that there is an increased incidence of venous thromboembolism in our population, the practice of instituting thromboprophylaxis at admission is remarkably low in these retrospective studies. Next slide, please. So VTE is not just a Western issue. VTE incidence in India is significant, like we saw in the study that I quoted earlier, 17.46 per 10,000 admissions. That's pretty significant. Next slide, please. So what we're going to do is to just take two cases and just look at various issues involved in their management. They are not specifically related to thromboprophylaxis. Let's start with the first case, please. Okay. So first case is a 73-year-old gentleman who presents to us with symptoms of shortness of breath and chest pain upon exertion, and is a known diabetic, hypertensive, and also has hyperlipidemia. Does not have any history of previous venous thromboembolism, and he's otherwise been well, fairly ambulant. He presents to us with mild respiratory distress and tachycardia and a mild tachypnea, and on measurement, his oxygen saturation is 87%. So this, of course, raises a possibility of a pulmonary embolism. Next slide, please. So his cardiac examination, ECG, everything is unremarkable. And his chest X-ray doesn't show much except for a slightly increased cardiac silhouette. And there's a small, tiny left pleural effusion, but otherwise the chest X-ray is normal. Rightly so, because of the combination of tachycardia, tachypnea, and a low saturation with chest pain. He undergoes a CT pulmonary angiogram, which shows a large saddle embolus with bilateral occlusive thrombi. And there's also non-occlusive emboli in both right and left pulmonary arteries. So this gentleman has got a significantly large pulmonary embolism. Now the next slide, please. Of course, once we've confirmed that the diagnosis of pulmonary embolism, we need to decide on what is the right way to treat this particular patient. How we treat depends a lot upon the presentation. So, of course, there are several scores to look at severity of the pulmonary embolism, especially the pulmonary embolism severity index. And the main points that we tend to take into account when we treat a patient with pulmonary embolism is to look for whether the patient needs thrombolysis or not, or whether the patient only needs anticoagulation. There is, of course, the high-risk pulmonary embolism based on PESI, mainly with hemodynamic compromise, which, of course, in most situations, unless there is a high bleeding risk, one would go for thromboprophylaxis. One would go for thrombolysis, followed by appropriate treatment with low molecular weight heparin or an oral agent. So if it's low-risk pulmonary embolism, we would just treat him with low molecular weight heparin. If it's a really ultra low risk, we would just treat him with, we can even treat him as an ambulant patient on oral newer DOACs. So it all depends upon what is the severity of the presentation. Our patient in question did not have hemodynamic compromise. His NT-proBNP was slightly on the higher side. So it was decided that due to the lack of hemodynamic compromise, he was admitted and started on enoxaparin. His weight was 80 kilograms, so he was started on 80 milligram BD. And he was continued on enoxaparin for 10 days, although most of us would just continue for the first 5 to 7 days and start on an appropriate oral agent. So after 10 days of enoxaparin, he was sent home on apixaban. So at this point, we need to discuss a few things, actually. So for time immemorial, we've had warfarin, vitamin K antagonist as a standard treatment. So what are the newer agents that we have today for treating patients with pulmonary embolism or any venous thromboembolism? Of course, the ones that we have in India are the two oral 10A inhibitors, which is rivaroxaban and apixaban, and one oral thrombin inhibitor, which is dabigatran. So is there any evidence to suggest that patients with a newly diagnosed pulmonary embolism will do well on the direct-acting oral anticoagulants in comparison with warfarin? Of course, there's right now overwhelming evidence that apixaban, rivaroxaban, or dabigatran are non-inferior to vitamin K antagonists like warfarin, and they also carry less risk of bleeding. So based on those trials, I think nowadays most patients, unless there is an overwhelming reason like presence of antiphospholipid antibody syndrome or any other high-risk thrombophilic abnormality, would go on a direct-acting oral anticoagulant. So rightly so, this gentleman, after having his initial 5 days of low molecular weight heparin, was discharged home on apixaban, 5 milligram BD. So he continued on apixaban for 3 months. Next slide, please. So this is the Amplify study illustrating the fact that if you look at incidence of recurrent venous thromboembolism, when compared with enoxaparin, apixaban had a lower incidence. This was statistically significant, 2.3% in the apixaban arm, whereas 2.7% in the low molecular weight heparin with warfarin arm. Similarly, if you look at major bleeding with apixaban, there was a significantly lower incidence of major bleeding compared to patients who went on vitamin K antagonists following enoxaparin. If you look at major or clinically relevant non-major bleeding, the bleeding incidence was much higher with the low molecular weight heparin and vitamin K antagonism. So this is starting this gentleman on apixaban is evidence-based. Similar to trials for apixaban, there are also trials for rivaroxaban and dabigatran. So of course, we've got the Einstein trial, which demonstrated that rivaroxaban was equal in efficacy compared to apixaban in patients who with venous thromboembolism when compared with patients on vitamin K antagonists. So you've got a wide armamentarium of, at least we've got 3 agents from which we can choose in India. And of course, how you choose depends upon certain individual characteristics, etc. So this patient was rightly so changed over to apixaban after his initial low molecular weight heparin treatment. Do all these patients need a low molecular weight heparin lead up before DOACs? Of course, patients who present with low risk PE, etc., can be started directly on DOACs rather than have this lead up to low molecular weight heparin, except in dabigatran and edoxaban, where you have to have the 5-day lead up with low molecular weight heparin. With apixaban and rivaroxaban, you do not need that. Next slide, please. So why did we choose apixaban? Of course, there's trial data to say that it's as good as warfarin with a low bleeding risk. And more importantly, these agents have got predictable pharmacokinetics, and it allows us to use a fixed dose regimen. And overall, there is improved patient outcomes. So this patient was started on oral apixaban after finishing his low molecular weight heparin lead up. Next slide, please. So previous slide, please. So, of course, with this particular patient, he had an unprovoked pulmonary embolism. So, how long do we treat is another question to answer. See, most patients with venous thromboembolism need to have 3 to 6 months of treatment at least, except in certain situations where we can give extended thromboprophylaxis. And of course, there are various agents one can use for extended thromboprophylaxis. I think the next case is to illustrate that particular aspect of treatment. Next slide, please. Okay, this is a 44-year-old lady with no medical problems whatsoever. She was diagnosed 6 months before with a large proximal deep venous thrombosis of right lower extremity, and also had a PE protocol CT done because she had slight chest pain, and that demonstrated bilateral multiple pulmonary emboli. So she was initiated on therapeutic anticoagulation with warfarin for reasons not very clear. So she had, there was no specific risk factors, not like she had antiphospholipid antibody syndrome, but she was started on anticoagulation with warfarin. Now she comes to your clinic and comes to our clinic. At the end of the first 6 months, she's had fairly a good treatment with mostly being under therapy, mostly having therapeutic INRs. Because she had an unprovoked major pulmonary thromboembolism, our practice would be to continue long-term anticoagulation. Now, the question in front of us is what would be the appropriate long-term anticoagulation? What would be the appropriate agent for long-term anticoagulation in this lady? Of course, we can continue warfarin, that is the vitamin K antagonist long-term. Now, the question she asks us is, can I have something a lot more convenient? I'm not very happy with, doing repeated INR testing. So is there any evidence to suggest that we can use newer anticoagulant for extended thromboprophylaxis? That is the question we try to answer with this particular case. Next slide, please. So in this particular patient who's had an unprovoked pulmonary embolism, what is the most appropriate next step management? So, of course, we know that warfarin, we can continue as long-term thromboprophylaxis, but in a young lady like her who has got an active life, there are several restrictions placed on lifestyle by using vitamin K antagonists long-term. Dietary restrictions, need for regular laboratory monitoring, and several such inconveniences. So we have a detailed chat with her and say that there is enough evidence to suggest that you can use an agent which doesn't need regular INR monitoring with fixed pharmacokinetics. We discuss apixaban, rivaroxaban, etc., and decide to use apixaban for extended thromboprophylaxis. So what is that based on? That's based on the trial data from Amplify Extend. So of course, we know that compared to vitamin K antagonists, apixaban provides us with the convenience of ease of dosing, and also is proven to be efficacious and is safe. Now, the next question is, what should be the dose of apixaban that we should use for extended thromboprophylaxis? Should it be 5 milligram BD? Should it be 2.5 milligram BD? Again, that question has been answered by Amplify Extend, and there is no difference in recurrence rates compared to 5 milligram BD or 2.5 milligram BD. So in this particular lady, we would go ahead and use apixaban at 2.5 milligram BD. Can we use rivaroxaban similarly in such a situation? Of course, one can use rivaroxaban too. The final decision comes to based on individual patient preference and certain retrospective data. Next slide, please. So apixaban in extended treatment of prevention of DVT and PE, the evidence comes from Amplify Ext study, which compared safety and efficacy of apixaban 2.5 milligram BD and 5 milligram BD dose with placebo for extended treatment of VTE. The study reported apixaban to be associated with decreased rates of death and better safety outcomes at an extended duration of 12 months when compared against placebo. So there is clear evidence to suggest that one can use apixaban to address this extended issue of extended thromboprophylaxis. Is there any difference between apixaban and rivaroxaban? Of course, we all know that there is no direct head-to-head trial, but there is some retrospective data to suggest that apixaban might be better than rivaroxaban in terms of higher efficacy and decreased bleeding. Of course, you have to take this with a pinch of salt, as it's a retrospective data. There's no direct head-to-head comparison between apixaban and rivaroxaban. Next slide, please. So study findings demonstrate superior outcomes associated with apixaban and its extended therapy for DVT prophylaxis, and it's also useful as a recurrence prevention measure. Next slide, please. So I think what I did with these two cases, hopefully convincingly, is to firstly, with the first case, establish that in today's world, when patients present with pulmonary embolism, once they've had their initial treatment, whether with low molecular weight heparin or without low molecular weight heparin, you have choice of several direct-acting oral anticoagulants, and apixaban is one of them, and it is efficacious, it's as good as warfarin. And with the second case, we've established that there are patients who need prolonged anticoagulation, a select group of patients who do not have a high bleeding risk but have a high thrombosis recurrence risk. And in them, we can safely use direct-acting oral anticoagulation. It could be apixaban or rivaroxaban, so depending upon patient and pharmacokinetic characteristics. Thank you very much for your patient listening.
Thank you, Dr. Prabhu. I think we'll just move ahead with the questions. There are already a couple of questions in the chat box. So the first question again, Professor Gregoire, is how do you place thromboprophylaxis in the perioperative ERAS protocol, the early recovery after surgery? Is there any difference in thromboprophylaxis for these patients, or you think they don't need prophylaxis at all?
What do you call ERAS?
Early recovery after surgery means you enhance, you quickly.
Oh, yeah.
Fast track surgery.
Yeah. So as you know, right, for hip and knees, for example, there are a new set of studies as well looking at whether aspirin could be sufficient for thromboprophylaxis. And there is a study that we are doing in Canada now comparing rivaroxaban to aspirin after, again, hip and knee arthroplasties and using these fast track. Certainly, that's a trend to follow, right? See how things unfold. I'm often a bit concerned when I see them pre-op, and certainly if there is anything that grabs my attention, or if they had a previous VTE, or if they had, I think that's really good for low risk patients overall, right? And if recovery proves being as easy as expected, as soon as there is something that are on our way or any delay, then I think we should go back to our usual habits kind of thing. But certainly, in terms of it's a bit of a debate about what's in immobilization versus a surgery, right? You could be as mobile as you want, you could still clot. Like the challenge of the hemostatic system is likely as important as the immobility, right? So I don't think it's because someone is going home the same day that it completely annihilates his risk of thrombosis if he did get a significant challenge from the. So again, word of caution there.
Another question, I'm being in intensive care myself, Professor Gregoire, this thing about renal failure. Now calculating creatinine clearance is okay in patients with stable renal function, but in the ICU, people have acute renal failure, where all these formulae for calculating creatinine clearance are not accurate at all. So we have to assume that once they have acute renal failure, they probably have a zero GFR, and these are patients with sepsis who are on the one hand higher risk for DVT. So what do we do? Does that mean that we have to use unfractionated heparin in every patient with sepsis and acute renal failure? Or what would you say?
Well, you're right. Yes, that's a very good point, right? That certainly we know that the creatinine is very delayed in a patient with acute kidney injury, and so if you fear that that's where the patient is heading at, then yes, likely unfractionated becomes the only option if they're getting unstable from that perspective. Not to say that when they come in, it depends. Yeah, I guess it depends on how it unfolds, right?
And you said the Medinox study, actually no study has been done in patients with lower dose of heparin, 20 milligram, and so maybe that study needs to be done in patients with, because I think in India most of us are just trying 20, and though there is no evidence, many of us are just not very happy with unfractionated, and we use 20
That's the
mg
thing, right?
rightly or
And I
wrongly.
showed you the results of bleeding. Yeah, I agree. That would be a good one. Yeah.
Dr. Prabhu, any comments on that? What do you all do? I mean, patients, this is a situation we have all the time. Sepsis, acute renal failure. What do you all do? You use unfractionated heparin or what?
No, I think it depending upon the creatinine clearance, I think we tend to use low molecular weight heparin. In patients with acute renal impairment, I tend to use fragmin, dalteparin, because there's data that if you look at accumulation of low molecular weight heparin compared to enoxaparin, with dalteparin, it's safer to use where there's acute
But at
renal
30
impairment.
or above, if it's 0, then at creatinine clearance less than 30, more than 30 maybe, but at 0, I'm not sure. I'm not sure.
No, sorry, I didn't realize you were talking about 0.
I'm saying in acute renal
Sorry,
failure, you would
it's
assume that the
okay.
creatinine
Okay,
clearance
I
is
beg your pardon.
very low.
So, of course, if the
No, but
creatinine clearance is close to 0, you wouldn't use any low molecular weight heparin, and it's got to be
So that's the
unfractionated.
most patients sepsis. That's
Yeah,
what I
yeah.
meant. But that means in the ICU, it's a little tricky. I mean, that's
Yeah.
Mm.
So I didn't realize you talked about a situation where the creatinine clearance was 0
But
because it's
no,
not
but thank you
accurate
for
in
raising
or
patients.
you're
less
right.
than 30, let's say.
Yeah.
The other question, of course, in our country, Doctor, I'm sure it's there in the West as well, that almost everybody is on double antiplatelets. Quite often, not everybody, but many patients are on aspirin and clopidogrel as well. So in this situation, and many of them come with a stroke or come with the infarction and they need DVT prophylaxis. So what would you do? Are you comfortable using 3 drugs, 2 antiplatelets and heparin, or would you stop one of the antiplatelet agents?
Well, it depends upon very often what the indication for the antiplatelet agent is.
Or they had a stent or they had a
Yeah,
stroke, or
if
I
it's
mean, in the
not a
past.
recent stent, then in such a situation, I think depending upon the how you estimate the bleeding risk, you may have to stop one of the antiplatelet agents at least. It again depends upon what we consider the bleeding risk is in these kind of patients. But of course, if it's a
Yeah.
recent stent, it becomes very tricky. So
What would you say, Dr.
Agree.
Gregor? So sometimes you have a patient who's
Yeah.
been infarct in the last couple of months, had the stent, and now comes with some other illness. And so, what would you recommend? Would you recommend giving all 3, or what would you do?
So I agree with what Dr. Prabhu was saying, right? It's a lot depends on the when and the why of the dual antiplatelet agent. A reassuring point in the symptoms trial that we published last year, that was a clinical trial of enoxaparin versus placebo in elderly medical patients admitted to hospital, and like almost 40% of them were on aspirin on admission, and actually they were maintained on aspirin. It was aspirin alone, right? So it's a bit different, but there was no increase in the risk of bleeding in the subgroup of patients who were already receiving aspirin. So we know that if you're able to do aspirin alone, then you're safe to use for sure. If they are on the dual, well, the issue is that doesn't do nothing on the risk of venous thrombosis, right? So it doesn't do much. We know that aspirin, like antiplatelet agent, might reduce the risk of VTE by maybe 20, 25, 30%, but not more than that. So maybe that's a case of, if you feel that they're really high risk of VTE, I think I would use the 3, the PROF, right? Mitigating risk of bleeding. But certainly, I think I agree with Dr. Prabhu that the first step would be, okay, do they still really need to be on? Because as you say, fair enough, recent stent, but that's a different beast, right? And if you feel that the risk of bleeding is high, then mechanical thromboprophylaxis might be the only way to go. But my experience is that in most cases, this dual antiplatelet was just forgotten there forever, right? Just yesterday, I saw a patient like that who was going for surgery, and they were on aspirin and ticagrelor, and they were asking me what to do after his upcoming surgery, and they were on the dual for 7 years, and back then the cardiologist had said, let's do that for 3 years and stop, and that's it, right? So that's to me that's the most common situation.
It happens in India as well. Another interesting question, relevant quite to India, and probably in India, quite often pregnant women go home to their mothers during the 3rd trimester for the delivery. And so, there are obviously 3rd trimester is that. So, do you recommend prophylaxis during air travel to these patients? And the question also was, so obese patients who are traveling or cancer patients who are traveling, would you recommend during prophylaxis during travel?
Yeah. Well, pregnancy, I think in itself, if they didn't have, usually in pregnant women, if they never had a clot themselves, right, or if they don't have another strong risk factor, I don't think I would. I would say, sit at the aisle, not at the window, go for a walk in the corridor every hour, wear your compression socks, drink plenty of water. I don't think I would use, because the last thing you want is to do a shot of low molecular weight heparin, and they might bleed as well, right? And they are on the plane. So unless there is a specific risk profile, I don't think I would do that.
The other question is about extended prophylaxis. See, for hip surgery, there are some studies who have said that after discharge, you could put them on aspirin. 1 week in hospital, you give them LMWH, and then you continue at home with aspirin. Do you think that's a valid strategy for the other situations where you mentioned extended prophylaxis required, like obesity or cancer surgery? Extended
Yes. So
with aspirin at home, and because patients are reluctant to take the injection at home. So patients.
yeah, well, if it's hip and knee, they can use a DOAC as well, right? We have a Pixamon rivaroxaban study showing that that works as well for, and again, that's what I was alluding to before, right? We have these EPCAT studies. So the first one was, aspirin versus LOMO for 4 weeks, and then there was a EPCAT 2, which was low molecular weight heparin during the hospital stay, and then a discharge randomized between keep going on either LOMO or Xarelto or aspirin. And now we are doing the EPCAT3, which is right after the surgery, aspirin versus the rivaroxaban. But again, I think back to your point, I think that's fine. And the EPCAT2, like the aspirin, after discharge seem to be sufficient, but that's really only for low risk patients. Every time you identify an extra risk factor or a previous VTE or, as you said, cancer, or then I would stick to our usual recommendation of using an anticoagulant for 4 weeks.
But people are compliant with taking injections at home after discharge. I mean, that is the.
Well, yeah, you're right. I think, but if it's with a DOAC, there is no reason why there would be, except the cost, right? That might be worse than with aspirin. But you're right. If they say, "Oh, I won't take it," or "I can't afford it," and I don't have insurance, then that's when I would say aspirin is better than nothing. But generally speaking, when we look at studies of aspirin for secondary prevention of VTE, like a bit like the Amplify extension that you showed, right? But in the Amplify extension, the risk reduction with the Pixaban low dose is like 90%, right? It really, really reduces the risk a lot, while aspirin would only reduce that risk by 20 or 25. So we know that it's a much less good medication in terms of risk of VTE.
Dr. Prabhu, any comments on this? Would you also?
So with
aspirin versus for.
Yeah, I think I agree with Professor's comments, especially the pregnant woman. If there's no previous VTE, if there's no indication to treat them, to keep them on thromboprophylaxis throughout the pregnancy, there is no need for any thromboprophylaxis while they're traveling.
No, he was talking about somebody in the US, a pregnant lady coming back to India, long haul flight.
Of course, that is a very special situation. Even then, it is kind of very difficult to. There's not going to be any evidence-based guideline because it's such a unique situation. Unless, let's say, she doesn't have a past history of venous thromboembolism. She's had previous pregnancies where she's not been complicated with venous thromboembolism, no strong family history. I would just advise her to use the same measures that Professor just alluded to. But of course, there are some special situations. If, let's say, she's had a previous pregnancy-related venous thromboembolism, first thing I would ask her to do is to completely avoid that travel in the 3rd trimester, unless it's absolutely necessary. That would be my first advice. Of course, if she's insistent on going, then we'll have to work out something for her. It might be a low molecular weight heparin just before she boards, but I will have to explain to her that she's taking an unduly high risk of recurrence of thromboembolism. But otherwise, I think I'd agree with what Professor said. And again, with aspirin and DOACs, I think the degree of prevention with aspirin is considerably lower in terms of, it's inferior compared to DOACs, but it's better than nothing.
Thank you, Dr. I think one question is a question about D-dimer, which I think is more misused than used, especially during COVID. But anyway, there's a question about, would you use D-dimer to decide how to, to re-stratify? Dr. Gregoire, your comments on the use of D-dimer, if it has any use at all?
Yeah,
deciding about
that's why
prophylaxis.
I think you gave the answer already, right? I think, as you said, during COVID, when we had all this literature about D-dimer and how they were associated to the risk, eventually we saw interesting data coming up later that because it was fantastic levels of D-dimers that we had never seen before, right? The lab, I think our lab used to say, oh, greater than 10,000 and that's it. And when we started COVID, they said, oh, let's dilute because they're all greater than 10,000. And so they were diluting the sample more and more. And then it was greater than 20, greater than 40, greater than 60,000. But eventually, I've seen some studies, interesting, showing that part of it was resorption of the endobranchial deposits of fibrin, right? So there was so much fibrin local inflammation, and that ended being resorbed into the systemic circulation. Hence, so part of it might have been hypercoagulability, but part of it was just like the natural evolution of the disease as well. But beyond that, as you say, I don't think there is any robust data to say that the D-dimer, we should monitor that every day or anything like that, right? What we have is, I showed you some example of the improved score, and there is an updated version where they added the D-dimer into it. So one D-dimer determination at the beginning of their hospital stay, and then those with a D-dimer greater than 1,000 would be at higher risk of developing VTE, right? Likely being the reflect of the intensity of the aggression by their medical illness more than anything else. But I don't think it means that that's something we need to monitor on a regular basis in admitted patients.
Many hip surgeons somehow do D-dimers pre-op. I don't know. Have you noticed that, Dr. Prabhu, in your experience as well? I don't know.
No, I don't think our orthopedic surgeons do D-dimers either preoperatively
No,
or
ours do. I don't know for what
just
reason.
post-operatively. I think they just use standard thromboprophylaxis. I don't think they try to find out what the D-dimer levels are. With that question, I think in critically ill patients, I think D-dimers are more or less very difficult to use as a guidance as to dose your thromboprophylaxis.
I think we've had a fairly fruitful discussion. I think there aren't any more important questions. So I think thank you both. Thank you, Dr. Gagwa. Thank you, Dr. Prabhu, for enlightening all of us and for, I think, like I said, leading us from darkness into light, at least for most situations. And so hand me back to the people from EmCure.
I think I
Raunak,
have nothing much to, yeah, sir, I have nothing much to say. I think it was indeed a great webinar. And thank you everyone for your time. And good night to Dr. Hegde sir, Dr. Prabhu sir. And good day for you, Professor. Thank you so much.
Thank you, everyone.
thank you. Thank you.
Thank you.